అది రాగానే తయారైన వెంటనే ఓకే. సో I welcome as a secretary Iaptcb, I welcome my president Lakshman Garlapati sir and my treasurer RSV Sri Krishna and Daru Ranganath sir, who is the chairperson of the infectious disease chapter, and incoming president Dr. Sugunak Reddy garu, and Arjun sir, Central IAP EB member 2023, and Murari SMO Hyderabad. Welcome sir. Sandeep Patil, you are welcome for this session, and will be shortly our chief guest of honor J Venkati will be joining our webinar. The webinar is exclusively because we are seeing since 20 days, 30 days, more cases of mumps daily in the urban and rural community also. So in order to send a message to the government and other people, higher officials, we want to conduct an exclusive webinar and education for the pediatricians also, exclusive webinar on mumps outbreak. So I welcome you all for this. Sri Krishna, please take care and hand over and do the rest of the things. Thank you. Thank you, one and all.
Thank you, Dr. Sridhar. Thank you for setting the stage. I'll now request the President of IAP Twin Cities, Dr. Lakshman Garlapati, to please say a few words. Over to you, Lakshman, sir.
Yeah, thank you, Dr. RSV and Dr. Sridhar, and all the seniors who are participated in this group, Dr. Ranganath sir, Dr. Arjun, Dr. Sugunak Reddy, and Dr. Sandeep, Dr. Suchitra madam, and Murari Prasad also joined, I think. And I welcome you all to this very important, timely based, important webinar on mumps. And many EB members were requesting to conduct this webinar. And this is a really, like, as our secretary said, 20-25 days, but I am seeing from last 1.5 to 2 months, almost sometimes I am having a 10 to 15 OPD cases of mumps in my OPD in a day. So such is the situation. So definitely we need to, we advise, we recommend measles, mumps also to be included in the MR, including in the place of MR, we should recommend MMR also, because this is almost like an epidemic or pandemic, going to be pandemic. And of course, we are seeing very less cases of complications. And I welcome all the participants to give their opinion regarding the inclusion of mumps in the MR. And over to Dr. RSV.
Thank you, sir. Now I'll request our president-elect and the one who will be taking over from Dr. Lakshman next year, Dr. Sugunakar sir, to please say a few words. Dr. Sugunakar sir, please.
Dr. Sri Krishna. Good afternoon, Dr. Lakshman, Dr. Sanjay sir, Dr. Ranganath sir. Good afternoon, Dr. Sridhar. So welcome to this webinar. And today's daily we are seeing in our OP almost 10 to 15% people are the mumps patients in the sun season. We are seeing many, but most of them are uncomplicated. So far we are seeing, and 50% of them are unilateral and some very few are bilateral. And this is the situation because of after the COVID vaccine, this is a COVID period. This we are seeing for the first time so many mumps cases, just because government there is no MMR, only MR vaccine is there, and in the private sector many people have skipped the MMR vaccine during the COVID period. That's the reason we are seeing so many MMR mumps cases. I request all the authorities to include MMR in the routine schedule, or exclusive mumps vaccination drive. We'll have like an MR vaccine drive. We can have a mumps vaccine drive. Thank you.
Thank you, Sugunakar sir. Thank you, Lakshman sir. Now I'll request our chairperson of the IAP Infectious Disease Chapter, and we are very fortunate that a person from Hyderabad is now heading this chapter for 2024 at the national level in IAP. Dr. Ranganath sir, he worked as superintendent of Nilofar Hospital, so he knows the public health extremely well, and he has worked with UNICEF, WHO on various programs, and is now heading IAP ID chapter. So I'll request Ranganath sir to please say a few words.
The mumps which I have seen when started my pediatric practice, I worked in Fever Hospital, which is supposed to be the quarantine hospital, where daily there were at least 50 to 60 cases of mumps outpatient, but a few, only 2 or 3 would be admitted. The indication for admission was persistent vomiting, pain in the abdomen, persistent vomiting, and very few cases with pain, all male children, pain in the scrotum, or a female who is having a hypogastric pain, or lastly, there is abnormal behavior or convulsions and presumed to be mumps encephalitis. These are the 3 or 4 cases which required admission. Of them, there were no deaths at all. This was the scene in 87 to 93. But once MMR was introduced in 85 or 87, the mumps did come down. But now the amount of people who are unvaccinated against mumps is very high. So that is why after 3 years of COVID, we are getting cases of mumps in epidemic way. Though it is a mild disease, the problem is quarantine is required, because in a class, if a patient is seen, detected, then the entire class is at risk, provided they have taken only vaccination in government setup, which serves with only MR vaccine, whereas private people, they get MMR. So if you stratify the patients who are coming, you invariably find 90% of them from MR group. That means people who have received only MR. So this was already insisted in our during previous MR campaign. Now the government, this time we will represent strongly that we have tried to limit the disease in children, but the child disease of mumps has to be prevented, and we request the government of India to include MMR, that means mumps, measles and rubella vaccine in place of MR vaccine, which will be beneficial, helpful to the society and helpful to the health of the children and of the nation. Thank you.
Thank you, Rangnath, sir. Before I go to Dr. Sandeep, let me re-emphasize the message from all the pediatricians. One, we're seeing a lot of cases of mumps which are coming with frank symptoms. Second, probably not very, very sick. Third, there is an urgent need to include mumps in the schedule, and we'll discuss more on the clinical management, when to refer, when to admit, and also more on the vaccination part. With this as a backdrop, it's our pleasure on behalf of IAP Twin Cities branch to welcome Dr. Sandeep Patil. Dr. Sandeep is the sub-regional team leader of WHO, and he's in charge of all the WHO operations in Telangana and Andhra Pradesh. Dr. Sandeep, thank you for joining us despite you being in travel, and we much appreciate your contributions and our partnership of IAP with WHO on various fronts. We've been partners in the special IPV campaign, in the MR campaign as well, when there was an outbreak. So request you to please share your insights before we move on to other agenda. Over to you, Dr. Sandeep.
Yes, thanks a lot to IAP chapter for providing me this opportunity, and I'm really appreciate the concerns raising number of the cases, mumps cases. See, including a vaccine into the national immunization schedule, we have a higher technical body at India known as Iaptcb. There are multiple factors are discussed and then they decide. So let us see what happens. But the conscious decision taken by the Iaptcb, and Iaptcb has the not only from the government sector, it has all the experts from other sectors also, from IAP also they have. So at this level, I can't commit anything from our side or my side, but let us see what happens in future. And whenever, if I get the opportunity to raise, then I will also raise the concerns raised by the Hyderabad unit. That is from my side.
Yeah. Thank you, Dr. Sandeep. Anything else you would like the pediatricians to be aware of, especially related to surveillance, and anything else that we can contribute as a group of pediatricians to the society?
Yes, thank you, Dr. Sri Krishna. We are presently supporting the government ministry, WHO NPSP unit, which I am heading, for measles, rubella surveillance, acute flaccid paralysis surveillance for polio, diphtheria surveillance, pertussis surveillance, and neonatal tetanus surveillance. So I request all the pediatricians to report the cases to the concerned district DIO or the surveillance medical officer, so that we can collect the samples and we can send the samples to the concerned WHO accredited labs to see whether they are really those cases or not. And the samples which we send are sent to the WHO accredited labs. So these are tests are very high quality. Yes. So I request to report all the cases to concerned DIO or the SMO, so that we can put our efforts together for elimination of the disease of measles and rubella, and we continue our polio-free status. So for measles and rubella, I request that all the cases, irrespective of age, fever and rash cases, should be reported, maculopapular rash. This is the one request to all the pediatricians, so that we can work together for measles and rubella elimination. Yeah. Thank you, Dr. Sri Krishna.
Thank you, Dr. Sandeep. Now, in the current context, do you want us to report the swelling cases of fever plus minus swelling? Do you want us to track, or what is your suggested action?
See, what I suggest is, my opinion is, you can report the cases to the IDSP wing of the concerned district, so that they will note down the cases and we can come up with the burden. How much increase is there, how much cases? So if in future arises, we have a data so that it aids in decision making. So I request, it is better to inform the concerned district IDSP wing to the cases, so that they also come to know the burden, and we can take the government can take the actions, so that if it is necessary, we can deal the problem. So it gives the data, so that in future, if arises, it will aid in the decision making and policy request.
Yeah, thank you. That's a very important point. It's not enough if we just see the numbers in our clinics. If we do not have a strong evidence, it's difficult for the government to take policy decisions. Everything is based on just the evidence, and that comes up only when the doctor starts noting it down. I think from the Pediatrics Association, we'll try to come up with a policy or a process in which all these numbers get reported, get counted. Hopefully, this will then be taken up for action in days to come, but at least the action starts with us, wherein we'll establish a simple mechanism wherein all this can be reported. We have a very efficient WhatsApp group wherein all the cases with fever and rash are being reported. And my thanks to the WHO team, especially to Dr. Murari, for promptly responding to all of them. We have been able to increase the reporting to a very series of combined efforts. And this again reiterates, sometimes if you are able to work together as a team, you are able to bring about better process, and that results in a change in the days to come. So we'll try to take those principles and see what best we can do, and also improve the reporting. And we'll see, we'll start with steps which are there at our end and see what next needs to be done. So this is a long journey, and the effect of COVID is probably what we are seeing right now. Thank you, Dr. Sandeep, for sharing your thoughts. And we'll again come back to you later after the webinar to seek your guidance and support, so that we can handle this crisis better. At the end, it is the pediatricians who are the face of the health. When the parents are asking us why this has happened, what needs to be done. And this question comes not just from those who have a sick kid, but also from those who are healthy. And these questions are coming to all of us, saying, if this has happened to my neighbor, how can I prevent it to my child? So we need to answer all this. And with this background, now we'll move on to the panel discussion. The DMHO currently is tackling a crisis wherein there is a fire in one of the complexes in Hyderabad, and there are some people who injured and urgent attention is needed. But he said he will try to join, and he'll send his message across, and we'll definitely work with the DMHO Hyderabad, WHO Hyderabad, and the entire government officials, we'll ensure that we take up steps at our level, and whatever action is required at various stages, we'll take it up. I thank Dr. Suchitra for joining in despite her schedule of inspection. So let me begin with you, Dr. Suchitra. Probably I'll come back to you later. Let me begin with Dr. Murari first. Dr. Murari, if this question is very straight, we are seeing a lot of cases of mumps. What is the reason why the mumps cases have suddenly come up now? Is there any specific reason we can attribute to the current outbreak?
Yeah, that's fine, Krishna. So, Dr. Krishna, so fine, there is a cyclical trend of these kind of infectious diseases like measles, mumps, etc. So they keep on coming every 3 to 4 years. We see the cases, this epidemic, when it occurs, it will infect all the susceptibles who are unimmunized in the community, and it will cover everybody, and it will leave a gap. There won't be any rise of the cases like epidemic. So after 3 years, again, the susceptible cohort will be created again in the community. And when the susceptible cohort is created, and when the environmental factor favors the virus, it will replicate and it will infect all the susceptibles who are there in the community, of course, who are unvaccinated, especially in the community. So definitely this cyclical trend of 3 to 4 years occurs every year. If you remember, we have seen this same trend in 2020 also. The measles and also mumps viruses together have ramped up in the community in the same Telangana state and Hyderabad in the overall India. So this keeps on coming whenever the susceptible cohort has been developed in the community. Sri Krishna, this is the main answer.
Is there any such trend in other states or other districts? I am aware of only the Hyderabad scenario. How was it in the rest of the state and other states?
Mumps case also, we are hearing that mumps is on rise in the other states also. Like the same has occurred with the measles in 2020 and also in 2023. It is everywhere, pan-India. Of course, in the world also, pan globally.
Okay. Is the lack of vaccination drive during the period of COVID in any way responsible for the current outbreak? Of course, the cyclical trend. Perhaps if COVID were not there, would it have still occurred, or what is the presumption?
That doesn't make due to COVID, because we don't have MMR vaccine in routine immunization of government setup. Most of the government setup only covers most of the children, And so as there is no vaccine, even though COVID not has occurred, definitely there would have been a cohort created for mumps related rise in the number of cases.
Yeah, thank you. That's the reason I specifically asked this, because the majority of them still did not get mumps vaccine. So there's, although it may be small numbers of those who took the vaccine in private and might still get it, but unless we have strong data, we can't attribute causation effect to it. But a majority of them were not immunized with mumps, and COVID may or may not be really responsible for that. But what definitely did affect was the routine immunization and people's emphasis on taking the vaccine on time. And these are factors that would have resulted in a spike of other infections. And we'll discuss more on that. Thank you. Now I'll request Dr. Suchitra. Dr. Suchitra, if you're there. Dr. Suchitra, to please tell us what is the presenting symptoms. Ma'am, you are seeing all these patients at Gandhi Hospital, probably the one who's seeing the maximum number of mumps cases every day. So please tell us, one, what is the ground scenario at Gandhi Hospital? What are the presenting symptoms? Also continue and tell us, when do these cases need admission? And what is the advice for us pediatricians in the private sector? When do we admit such cases?
Yeah, thank you, Dr. Sri Krishna. It was nice for the invitation that you have given for IAP. So thing is, like mumps right now, what we are seeing is an OP basis. Most of the cases we are seeing daily are with fever, history of fever, followed by 2 to 3 days. There's a swelling noted in the parotid region, which is extending to the neck. Usually we see bilateral as called as that, but as previous scenarios. But in this present day scenario, we are seeing 75% of the cases as unilateral parotitis. And these children, when we have seen last 3 months, we have had a data of around 74 cases. In the 74 cases, we have seen that 60 cases were having unilateral parotitis, and they did not need any admission. Only 7 cases which were reported to this IDSP through our AFI team, that is 7 admissions were there out of the 74 what we have seen in the last 3 months. So these cases admitted with acute abdomen with vomiting, excessive vomiting, presentation, and only one case had a pancreatitis kind of picture, and one was aseptic meningitis that we have seen. That child also recovered. There was no fatality reported as of now. And hearing, yes, hearing loss and all, these are sensory neural hearing deafness. We will see it at a later point of time because the infection is recent. We can see these evolving over a period of time. So we have to keep them following up. And coming to the point that knowing about the basis of this mumps virus, which is paramyxovirus, and there will be like prodromal symptoms of myalgia, fever, mild grade of fever, myalgias, and it may subside on its own without any parotid swelling also. But when these cases are presented with acute abdomen or vomiting, severe vomiting, or a male child who is presenting with a testicular pain, should always suspect these cases in this scenario when there is an outbreak. This is what is there. And because this virus is like host limited, only human is the host. Only thing that we can do is there is no specific management or a medication for this. So isolation is better. So not to send these children to the school for the respective days, that is a 10 days period. So they have to be isolated because total duration will be 14. Initial 3 to 4 days and then 10 days. So it comes around 14 days of isolation. That is in proven cases. And RT-PCR is the only test that that can be done to get this thing. While RT-PCR is the one. So if you have a lab permission, then we can go ahead. Here we did not have the lab facility, of course, but clinical basis was sufficient enough for us to. And even today morning, also 2 cases in OPD basis we have seen as mumps cases. This is what is the report from our own center. Regarding other centers, also we have heard that how this virus is being spread, and all these cases are only MR vaccinated children. The age groups are like from 2 years to 12 years. We have seen all these cases from 2 years to 12 years.
How long do the symptoms last, and how much time for the swelling to come back to a minimal size?
Usually it is said as a theoretically 7 days they say, but we are seeing the swelling even up to 10 days also in few cases. Swelling with the pain, if it is the cold and hot fermentation, if it is a hard swelling, we ask them for hot fermentation. If it is a painful swelling, go for a cold compressions. This is what is to be followed, and excessive intake of fluids also decreases this condition because the virus has to get washed out. That is the only remedy for the treatment. Analgesic have to be given. Ibugesic is quite good if there is no added infection per se. But no antibiotics. There is no
last question before I relieve you. When to admit or when to hospitalize certain cases?
Yes, when fever is not subsiding, after 3 days also, when high grades of fever. And second point, you have a atypical presentation like orchitis of pain, that's a pain, testicular pain. Or if the child is complaining of headache, continuous headache followed by a fever of 3 days or 4 days with the myalgias, and then irritable or confusion status of the child. When these conditions are reflected or noted by a parent, it is early to get them admitted and then look for this because there is an outbreak. We are supposed to evaluate.
Dr. Murari, at this time, is there any way in which we can send samples for confirmation? Because RT-PCR is for confirmation, although it's a clinical diagnosis.
So sample collection is not being done by WHO side. So we can take into IDSP. Even IDSP may not be doing that. We can take into that IDSP.
Okay, fine. I think we'll have to connect with IDSP and find out if there's a way in which we can send samples for these. May also help in epidemiological analysis or trying to subtype it. And this might be helpful for vaccine development and other purposes later. Then this planning kind of needs to happen now. Thank you, Dr. Suchitra, and thank you for sparing your time. I'll request Dr. Arjun to please come in. Dr. Arjun.
Yeah, good afternoon, Dr. Krishna.
So we've seen that there's a sudden surge in the cases of fever with unilateral or bilateral neck swelling. Please tell us what is the OP-based management and what is the, apart from what medications, what other advice do we suggest as pediatricians to these parents?
Yeah, thank you, Dr. Krishna. Before that, I'd like to give a brief overview. I have heard the authorities also, and I heard you people also. See, I feel in the modern days, any vaccine preventable disease has no place. See, in 2023, we are entering 2024. It is disgraceful that the vaccine preventable disease can occur in such a magnitude and such big numbers, almost epidemic proportions. just before dengue season, before rainy season, we have had measles outbreak. We have been reporting the cases to DMHO and other officers. Now, soon after the rainy season over, now we've seen epidemic of mumps which is happening. See, and the issue becomes serious to the authorities only it is a killer. If it is a killer, if it's got a lot of mortality or morbidity. Unfortunately, mumps is not an immediate killer. But how much of morbidity it is contributing to the society, unless we have a data or unless the gynecologists say how much of the sterility, male sterility is attributed to mumps, unless how much of deafness can be attributed to mumps. Leave alone, see, we don't even evaluate, we don't work out the economic costs of school absenteeism, absent from the workplace, and also spending on the outpatient, spending on some hospitalization whenever required. We don't work out this. We need to work out this in a modern society when the nuclear families are there and urban people, nuclear families, you end up losing job, don't go into work, school. All this, we need to work out the economic cost. So when you work out the economic cost, preventing a disease by a simple vaccine and to a vaccine that can be piggybacked on MR at a less cost, with low logistics, you can piggyback this mumps vaccine onto MR and make it MMR. So with MMR, and that too ideally 2 doses, not 1 dose. 1 dose is going to protect only 60 to 90%. 2 doses are ideal, and that too 1 dose should be started before my 1 year. So if you have a 2-dose strategy, the mumps can be prevented. By not only that, the measles epidemic was because of people, unvaccinated children, a large number of unvaccinated children during COVID times. Now COVID has come and gone. What COVID has taught us, only vaccine can save the humanity. Vaccine can save mankind. So modern times, there are so many vaccine preventable diseases. Likewise, no vaccine preventable disease should occur in such great numbers. So not only private sector, government sector also should play a major role. They're already giving very expensive vaccines such as the Haemophilus influenza, pneumococcal, rotavirus and all. We have been time and again requesting authorities to make it MMR, not MR alone. MR because measles is a killer, rubella or because it has got a sequelae and it can result in deformed babies. But mumps also is equally important. And that too, at a fraction of the cost, the mumps can be tagged on to this MR vaccine. So during MR campaign also, we've been requesting authorities, at least this is a wake-up call now. And for that, we need the numbers and also proof. And also, unless you follow the patients till full recovery, we cannot say whether the patient has had pancreatitis, oophorytis, or orchitis, or deafness, or any meningitis, aseptic meningitis, or meningoencephalitis. We are only seeing an outpatient. We're telling them that nothing to worry. It's not going to complicate much. Don't worry. But we are not following till the complete recovery. So especially the teaching hospital, they can follow the cases till full recovery. They can do some studies and present the data and represent to authorities why mumps has to be included in MR and why morbidity from mumps is also equally detrimental to the society. So, and as you know, it's largely OPD ambulatory treatment where you just give painkillers and anti-inflammatories and ice or water fermentation and maintain good oral hygiene, hydration, and all this. Basically, symptomatic treatment. If you suspect of any pancreatitis or any such complications, maybe you can observe the child for some time and also give some H2 blockers and all. But largely, so far, I've not had any admissions at all from mumps, let me tell you, because I made a handout, I made a flyer to the patients. I give the flyer to the patient, which is, and also even our government of India has got to also come out with 2 nice flyers. It's got the symptoms of mumps as well as mumps, the complication of mumps. So I give the handout, I educate them, I tell them, and I stress the importance of vaccination. So this has been my strategy. But once again, let me emphasize, I think no vaccine preventable disease should occur in such great numbers in modern days times. And it is not sufficient to say that every 3 years we get epidemic proportions. See, just as we eliminated smallpox and polio, even these have to be eliminated. You cannot say that they do occur. They do occur and they do occur across the globe, across all the countries from time to time, every 3 years and all. For the last 33 years, this is the largest mumps epidemic that I've seen. In my 33 years of practice, this is the largest epidemic that I've seen. I'm sure lakhs of cases are there in the urban sector in both the twin cities. So it's time we request authority to wake up to the magnitude of this problem and then try to do something seriously about it. And I also request that there has to be a very simple way of notifying mumps cases. Better would be app, because now app is used by every smartphone user. So instead of a website, app is much better to report any diseases. And there should not be any generally what happens, I'll tell you my personal experience. If you try to report cases, they come back to you like dengue cases, malaria cases, they come back to you, they say, they come and penalize you saying, how did you prove, how did you diagnose, and why are you going to media, why are you reporting these cases, and you don't have proper proof. All that dengue positive, all that suspected dengue cases are not real dengue cases, proven cases. So they should not victimize their practitioners. And the government has to take practitioners along. They have to take IAP along to strategize the health prevention programs, vaccination and coverages programs. Thank you, Dr. Krishna. Anything else?
Thank you, sir. You also touched on the point on vaccination. There is a myth of some side effects of MMR, especially with autism. Could you clear those myths?
These are some few reports have come from Europe and all have been disproved, and there's no logic behind autism because of mumps at all. It is totally disproved. And MMR is a very safe vaccine, and in fact, Serum Institute is one of the largest producers, and incorporating Jerry Lane strain, which is much better strain to compare to so many 11 other strains which are there in different MMR vaccines. So, and MMR, our own Indian company is one of the largest producers of MMR vaccine.
Thank you, Dr. Arjun. What is the current schedule you would advise for MMR vaccine in the private sector? When should they take it?
IAP recommends 3 doses as of now, one at 9th month. Earlier, it used to be measles standalone vaccine. Now it is MMR vaccine. No standalone measles is being given at all, even in government sector also. And another dose at 15th month, and the third one at 5th year. See, as you know, I just want to remind you, the people going to US for MS and all, they are also asking, it's become mandatory for the adolescents and big children to take another dose of MMR. So the more the doses, the better. But for a community point of view, for a coverage point of view, at least 2 days are mandatory. The 2 doses can give a protective efficacy of 90%. 1 dose is only 60 to 90%. So 1 dose is not sufficient. But however, even 1 dose also, you are going to see I told you, you have to work out the cost of school absenteeism, jobs absenteeism, and cost of outpatient treatment and hospitalization when if required. So that is minimal. The cost of vaccine is minimal compared to the loss of all this economic.
Next question, Dr. Arjun. We have some questions from those who are on YouTube. Does it cause appendicitis, mumps?
No. Actually, see, because it may cause pancreatitis or oophorytis, it may mimic, the abdominal pain may mimic, and also it doesn't cause it all. No appendicitis. The deafness, it is a long-term sequelae. Sterility, mere sterility is long-term sequelae. We have to take the data from physicians and OBGY. And immediately in pediatric age group, it is basically aseptic meningitis or occasional pancreatitis, only these 2 complications.
Yeah.
And basically, one more thing, whenever you have any parotid swelling, always do a throat examination, rule out that there's no follicular tonsillitis, because the submandibular salivary glands also is part of mumps. See, as you know, sublingual, submandibular, parotid. So all the 3 pairs of salivary glands can get infected in case of mumps. It is not just parotitis alone. And also, as specialists, we should rule out whether it is mumps parotitis or some other septic or non-specific parotitis. So, but largely community point of view, everything is mumps unless proved otherwise. Every parotid swelling or every submandibular swelling is mumps unless proved otherwise. We have to go with that notion.
Dr. Arjun, as I said, I have had one patient recovered from mumps on OPD basis, came after 10 days later, with DKA. So this is the only one case I had in this
Yeah,
season.
mumps, it's a paramyxin virus. Dr. Suchitra was saying it is known to affect pancreas. And Coxsackie and paramyxin viruses can do cause pancreatitis. I'm sure maybe it is because of pancreatitis that diabetes can result. Or another thing, post-COVID, I'm sure Dr. Lakshman Garu, you must have seen a lot of DKA cases just soon after COVID. Spurt
Yes.
of DKA cases we saw.
Yes, yes.
So maybe
Even this last 2 months also, I had 3 to 4 cases of DKA. One of the DKA was history of mumps, 10 days prior to the admission. The other 3,
So-
no, I didn't. They were not into mumps, fitting into mumps.
So that way, these kind of morbid cases, the morbidity that we have to highlight to the authorities that mumps, even though it's a trivial disease, may seem a trivial disease, may seem a simple disease, but it does cause complication which can be lifelong, like sterility, infertility is lifelong, deafness is lifelong. Likewise, diabetes is lifelong. It is not going to go away, not going to abate even after a few months of your insulin therapy. So we have to see it is definitely a significant problem that and the best thing beauty is it can be prevented. It can be prevented by vaccination. So let us wake up and try to prevent any vaccine preventable disease for that matter.
Dr. Arjun, does it result in mesenteric lymphadenitis or any other complications in the acute phase or in the chronic phase?
So far, I've not been investigating unless severe abdominal pain. Otherwise, we are not subjecting them for various tests. I said I use a patient handout and a flyer to educate them, and I tell them to come back to if any complications. So far, no major complications have come. Of course, nowadays you have seen any pain abdomen child is moving on with the ultrasound report of mesenteric adenitis, which is not significant, not so significant as adenopathy. But anyway, it's a transitory phenomena. It will subside soon after the infection wanes off.
Yeah, you touched the point on vaccination and how this entire thing can be prevented by a very simple vaccine, which is already available. Dr. Murari would like to know from you how does it work in public health when we know that there is a vaccine? What happens next? We have seen how pneumococcal vaccine is now into the routine immunization. So what are the different steps in which wherein a vaccine is available and how does it eventually reach into the routine immunization?
Definitely, boss, if MMR comes into place, it will definitely stop these kind of epidemics because government setup works for all the overcrowded areas and everywhere. These kind of areas, susceptible pockets will not be feasible to come to private sector and take MMR vaccine, which is costly. So definitely it work and it will definitely reduce the burden of this kind of mumps in the community after if the vaccine get launched into the government setup.
Yeah. So do we take these up in task force meetings or where does these points get discussed in the government?
Yeah, definitely. Here, DMHO comes into role here. You can take him into the line. You can report the cases to the district surveillance officer. In every district, you can get the login credentials, ID and password from the Iaptcb portal. Everywhere, every district is having a district surveillance officer. From he can provide you the login ID credentials. In that, you can report the burden of these diseases, how many cases you have seen, how many complications you have seen with them, and you can show the burden to the Iaptcb people, and they will definitely project. They can definitely project into the DTF files, and they can recommend for the vaccine. They can move.
Last words, Dr. Arjun. See, there's a lot of panic in the community now. The reason for the panic is their neighbor getting affected. And having heard these points on long-term side effects, especially involving the pancreas, a lot of parents get into worry and start to panic and ask us what can be done. Now, what can parents whose kids are not affected with mumps right now, how can they take care of their children so that their children don't get it?
In that case, only vaccination is the only way. Bump up vaccination or those are unvaccinated or those who received a single dose, they have to be. This is another second dose right away. But let me tell you, the infectivity of mumps is even before the swelling, 4 days before and also 5 days after the swelling. Also, it is infective. So before the swelling appears also, a child is infective. We're not sure whether already child has been exposed and child is having is in the incubation period. So because the parent may say that you give an injection, you give the vaccine, you'll come back to you saying that your child didn't develop mumps. It developed because of a vaccine. He may blame you also. That there's a flip side to that. So vaccine is the only way, and but still again, even though I'm educating parents, they're not so enthusiastic to take this vaccine. Like COVID, how on a mass level the campaign happened. So I feel in this regard, only unless the celebrities come on the media, unless the politicos come on media and say, come on to go and take the vaccine, either in private sector, and they can come on, the politicos, the authorities can come on media only if it is available in the government. If it is not available, they cannot say go and take the vaccine. At least for celebrities or our media, IAP also can issue public notices to come take the vaccine to the nearby doctor. And also, well, in this regard, I would like to remind you all, during the early phase of hepatitis B vaccine campaign those days, about 15 years back, and there was other people who were doing the MMR campaign also. It was like a seasonal business for some of the people. Some people were doing the typhoid vaccine, MMR vaccine, hepatitis B vaccine camps were being organized, and they used to charge cost to cost. So maybe IAP also can do some camps where you ask them to just cost to cost and then you give it free. You can do some mass vaccine campaigns in the private sector. As of now, I don't think government is going to include MMR straight away and asking the public to go and take the vaccine from your government center.
Yeah, in fact, you answered the next question which I had for you, which is what can IAP do? You've been the past president of IAP Hyderabad. You've led the MR campaign as well. So a few points which you've mentioned, I've made note of. One is where IAP can issue a public advisory asking all parents to take a list of precautions for their kids and not to panic. At the same time, reassure them of what general care can be taken, and also early detection so that we limit the spread amongst the susceptible population. Second is to check your immunization records. In case you are due for the MMR vaccine, please take it immediately without any further delay. That will protect you against the severe complications of mumps. Third, IAP can ask the government to increase the amount of information that goes from official and from the government side to all the public. And this has more weight because it's coming from the government's end. And this will be more reassuring the way the government came in and took control of the situation when COVID struck. Probably a similar kind of an approach can happen. And this request can come up from the IAP's end. IAP can also ask pediatricians to start reporting, probably the same way in which we have the fever and rash reporting, which happens in a WhatsApp group. The same thing probably can be tried. I'll see the feasibility of starting this, and we'll have at least one solid way in which we can have good reporting of the numbers of mumps. I'll request Dr. Murari also to be part of it. We'll be later on see what best we can do with that numbers, but at least we'll have some tracking of it, perhaps a Google form or anything that can be tracked at a later stage, and we'll see what best we can do. The public institutions must look at research, operational research, wherein they track those cases that are admitted, see for complications, and immediately notify all the pediatricians if there is a new development or any new finding that we perhaps are not aware of. All these should be taken up, and I'm sure with Dr. Lakshman at the helm of IAP Twin Cities branch and a very dynamic secretary, Dr. Sridhar, and our entire executive board, we should be able to handle this. IAP has been at the forefront in the past when there was IPV campaign, when polio struck in Amberpet, when there was a measles outbreak, and of course the big contribution of IAP when COVID came out. And there's no reason why we can't do anything for the current outbreak of mumps. We'll all work together and we'll come up with steps. Although it is quite some time since we have stepped up and accelerated our efforts, we'll make sure that henceforth due attention is given, and we have committed pediatricians across the city and also in IAP Twin Cities branch, so that we'll be able to take up more advocacy on this. Dr. Murari, any last words from you before we close?
IAP body is always a part of a district task force meeting everywhere. Whenever we do it for Pulse Polio or Mission Indradrush or any other routine mission background or any other health program, whichever is held. So IAP can join the DTF and it can recommend, give it burden, its burden, and it can show the burden. And it can recommend for anything, for any interventions at the district level.
Yeah, so there is a question, Dr. Arjun, there's a question on post-exposure. What can the child do? Can we have any post-exposure vaccination recommended for the child?
No, as of now, no post-exposure vaccination. As I said, the patient may be, I mean, he may be in the infective, in the incubation period also. And I think better to wait for 10 days period before you give an injection. If it's not developed after exposure within 10 days, the incubation period is 10 to 12 days. Na? So after 10 days, let us say 10 days cutoff period is the ideal period. So if it is not developed mumps, let us vaccinate them.
Yeah, and the last question, Dr. Arjun, before we close, how do we convince those parents? There are some misconceptions on the side effects. I know you have already said it is not true, but sometimes just saying it may not help. Is there anything we from IAP can do to increase the uptake of MMR vaccine, at least in the private sector? Because the issue is perhaps not the cost, but the belief on vaccination as a system of protection and also some perceived notions. What do you do at your clinic, and how does it help in improving the uptake of MMR?
See, first of all, we should tell them the vaccine MMR has been in use for last 20, 30 years, more than 30 years. And it's been proved safe. The autism has been on the rise only for the last maximum 10 years, let us say. So we cannot say that MMR is causing autism. It is a multifactorial disease, and even now it's still so abstract that what are the factors for autism? So that myth we have to dispel. Another thing is, except that egg allergy, those who are sensitive to egg, it is a very safe vaccine. Hardly any side effects. So that is what we need to. And also, it is given subcutaneously, doesn't cause any pain or local reactions and all. So if already elder sibling has taken, that itself is a proof. We should tell them, if your elder sibling is taken, for second sibling at least we can reassure them that it was safe for your elder sibling. Now it is even safer for your younger child. Or other siblings, other kids in the family have taken the vaccine. So that is a proof enough that the vaccine is safe.
Yeah, thank you. Dr. Murari, you had a point?
I want to just discuss about the surveillance, Sri Krishna, a few minutes.
Yeah, please go ahead.
So I thank Dr. Sri Krishna and all the IAPNs for giving this opportunity. You know very well, we are having acute flaccid paralysis surveillance in place. This year, Pakistan and Afghanistan have reported nearly 11 cases of polio positives in the neighboring countries. So there is a risk of transmission coming to our Hyderabad. So please be alert, and irrespective of the diagnosis, even while you are examining the child, if you feel 4/5 power, is bachcha ko kam hua ki nahi hai, when you are feeling borderline or ambiguity, you better report that case. We'll collect the stool samples and we'll rule it out as non-polio AFP. Regarding AFP surveillance in less than 15 years of age group, we'll collect the stool samples and rule it out as non-polio AFP. And the second one is, you're all aware, we already met about measles and rubella elimination by December 2023. But unfortunately, this year we are having a huge number of measles cases found in the field, reported by you and were lab confirmed. And also measles, we are getting positives in non-transmission phase. Even this month also, we have seen the measles positives in the field. You might be even seeing in your OPD. So kindly report all cases of fever, maculopapular rash, irrespective of the diagnosis. That can be in any age group. That can be a dengue rash, that can be a chikungunya rash, or rickets cell rash, or toxoplasmosis, mononucleosis, Rosella infant, irrespective of the diagnosis. Even initial stages of hand, foot, mouth disease also, if it is maculopapular, and even initial stages of varicella also, if it is maculopapular, you feel borderline, please report that case to us. We'll rule out as non-measles and non-rubella to maintain the sensitivity of the surveillance. And likely, we have launched DPT surveillance, suspected diphtheria, suspected pertussis, and neonatal tetanus. Suspected diphtheria, any child, any age group patient patient presenting to you with sore throat and patch-like thing in oropharyngo or laryngopharynx, you report the case to us. We'll collect throat swabs and see whether it's really diphtheria or not. And likely pertussis, any age group person presenting to you with the cough more than 2 weeks with any of the following symptom like post-acute vomiting, inspiratory woof, and apnea with cyanosis in case of infants, or paroxysms of continuous sleep, or you have a strong gut feeling this could be a pertussis, you please report that case, and we will collect the serum and for IgG serum, and we'll collect 2 nasopharyngeal swab to see whether it is really pertussis or not. And neonatal tetanus, after the birth, the child, if he feeds mother milk normally for the first 2 days of life, and from 3rd day to 28 days, if he has difficulty in sucking mother milk, you can report it as suspected neonatal tetanus. Or if you have strong gut feeling, this could be a neonatal tetanus. If the child has died without any cause, unknown cause related death within 1 year, 1 month of life, you can report that case as suspected neonatal tetanus to us immediately. There is no sample collection in this case. And also similarly, adverse event following immunization, you might be seeing many kinds of abscesses post-vaccination in your OPD or IPD. You might be doing IND with the support of even pediatric surgeon also. Any kind of abscess, sepsis, anaphylaxis, seizures episodes after immunization happening in the field, please kindly report to us. And I'm seeing the messages to clear the easy way of reporting. We have created a pediatric group, two groups we are having in the Telangana state for the pediatricians. So you can just simply post a photograph of the child, address and phone number with clarity, so that we will follow up the case, mentioning a minimal, like which mandal the child belongs, or which village or which district the child belongs, and child name, parent name, and the phone number. Just post a photograph of the child if possible, if you have any evidence of abscess or any reaction, so that we can put it in our training aspect, academic purpose also. So this is from my side, sir. Thank you so much, Sri Krishna, sir. So briefly, I can say acute flaccid paralysis irrespective of the diagnosis in less than 15 years, and baki fever, maculopapular rash, suspected diphtheria, pertussis, and neonatal tetanus. Please kindly report these cases to us, so we'll work on this. Thank you, Sri Krishna.
Yeah, thank you. Thank you, all the panelists. Thank you. Thank you, Dr. Sandeep, for joining in, and we'll make sure we put in our combined efforts to tackle the current outbreak of mumps, and we seek the support of all the pediatricians. We've seen bigger crises and have come together to contribute our best to the society. Rangnath sir, you have a few comments?
No, there's nothing. Whatever the thing that has persisted from 85 onwards is still reality occurring once again after that 29 years. So vaccinating the children is the only answer. Now we will collect the entire nation's data and try to present it to the government and raise the issue at higher levels and see that it is included in MR, with MMR as the basic dose. It's not simple. MR will not going to help to prevent the isolation of the children from going to the school with mumps as the cause.
Thank you. Thank you, Dr. Rangnath. Thank you, Dr. Murari, Dr. Sandeep, Dr. Arjun, Dr. Suchitra.
Yeah.
And we'll take up the steps that follow this webinar, and IAP Twin Cities branch will issue an advisory and also increase the awareness of the public amongst especially the high-risk groups about mumps and also the importance of vaccination. Thank you, everyone. Closing the session here.
Thank you, Dr. Sri Krishna.